The IMDC risk criteria were developed at a time when really we mostly were leaning on VEGF inhibitors to treat kidney cancer. And it's a very simple set of 6 criteria, 4 blood results and 2 clinical parameters that if you assess for a given patient, really predict their prognosis. Favorable risk will do very well, intermediate does intermediate, and poor risk has a poor prognosis. And so these were really developed just as a prognostic tool. Then we started to leverage them in the design of clinical trials with immunotherapy. And we learned that immunotherapy actually works best, ironically, in patients with poor and intermediate risk. And VEGF inhibitor therapy may work just as well or better in patients with favorable risk, renal cell carcinoma. And so in the recent guidelines that various groups have put together, treatment recommendations in the frontline setting do hinge on the patient's IMDC risk criteria. And that's based on the effect of risk on overall survival in large randomized trials.
When looking at the contemporary and currently used risk stratification algorithms that we employ in renal cell carcinoma, the IMDC criteria and the Memorial Sloan Kettering criteria, they have 4 features in common, which is time from diagnosis to treatment, anemia, hypercalcemia, and performance status. And these probably are the most important core features in these algorithms and help us define patient risk. Now, that doesn't mean that the LDH elevation or the high white count or the high platelet count that are seen in the MACCC or the IMDC respectively aren't useful. It's just that in the analyses that were performed with one versus the other, those either fell in or fell out. But I think the message here is that we have some pretty clear clinical parameters and laboratory parameters that really can help us decide about the underlying biology of these patients and which treatment then to use.
Favorable risk is, I think, the most interesting category. First of all, it's the minority of patients who are favorable risk. Only 10 to 15% will fit this category. Second, it's really a category limited to patients with indolent or slow-growing disease because typically patients with favorable risk had their kidney removed with curative intent and then years later grew a metastasis and became metastatic, such that their interval from diagnosis or surgery to treatment was greater than a year. The other way you can meet that criteria is if you have this slow-growing indolent disease and you're on observation. So right off the bat, that one criteria, you have to meet it to be favorable risk. You have to meet all the criteria to be favorable risk. It describes a slow growth pattern. So they have, by definition, a slow biology. The other blood tests are used in conjunction with that. And I don't really hedge on any of those factors. So if there's a patient who had their kidney cancer removed 5 years ago and has recurred late, yes, that's an indolent growth pattern. But if they have an abnormal lab value in any of the 4 that we use for IMDMC, they're still intermediate at least risk. So I go pretty by the book when I assess risk.
So in 2020, we don't have a really good way of mechanistically or biologically defining features that define good or intermediate or poor risk patients. We have the IMDCC and the MSKCC criteria, which help guide us. But with regards to linking, for example, good risk to some of the genomic features like PBRM1 mutations, SETD2 and BAP1 mutations, we're less good at doing that. I think we're going to see an evolution towards a link of molecular features to these clinical pathological features, but we're not quite there yet. So I would say that one of the key things we're going to be doing over the next couple of years is coming up with more robust genomic and biological correlates to these clinical and laboratory correlates that we're currently using.
Goals of therapy are a really important thing to address up front with a patient early in their diagnosis, because every decision you make about treatment really hinges on a shared understanding of what the goal is. For all patients with advanced kidney cancer, the goal is to keep them around as long as possible and feeling as well as possible and out there living their life with this disease. We do what we can to control it with medications, but the goal is always for their quality of life and length of life. And when we say it like that, and when we admit we can't cure them, that, focuses patients on the really important pieces of their treatment. They become more comfortable with taking treatment breaks for vacations, which we think is important. Some may become more comfortable with the observation approach when we frame it that way. And so I think the goals of care don't really change with risk. It's just the prognosis that changes. And what we're seeing is with immunotherapy-based combinations, we may be able to bend that prognosis for poor and intermediate risk, as these drugs tend to be more effective in that group of people. So in summary, I would say the goals of care don't change based on IMDC risk, but the expectations and outcomes and sort of long-term nature may be different.